Good evening. I want to welcome you to the campus of Central Baptist College. We are so glad that you came. We are so honored to have the governor of the great state of Arkansas with us this evening. As one of the college presidents in this state, he is challenging me to do better. And I like a challenge. And we always want to increase the graduation rate, but he's challenging us with distinct goals to reach adult learners. He is a friend, not only of higher education, as you know, of education. And Governor, I always talk to moms when I can tell they have a teenage son, and usually I can tell that because I ask them, and I'm always recruiting, as my wife would tell you. Today, one of the young ladies, she has a sophomore. She said, he just loves that computer coding class. Now, she really did say that. And we are appreciative of his challenge and things like the computer science initiative that causes us to think more future-minded about what our kids and our grandkids will be doing. Governor Hutchinson is a man of great leadership, a man of faith, and for that reason, we are so happy to have him on our campus tonight. Would you help me welcome Governor Asa Hutchinson? Yes, sir. Yes, sir.
Thank you. Thank you. I am honored to be on the campus of Central Baptist College. What a great institution. Dr. Kimbrow, great leadership that you provide, and you've been a friend for years, and it's good to be back on your campus. And thanks for letting us use this venue for my first governor's town hall meeting. This is the first town hall meeting I've had since I've been elected governor. I had a lot of town hall meetings in my past, but this is the first as governor, and it's about time. And I think it was appropriate that I come to Conway, that I come here to Central Baptist College for this town hall meeting. So thank all of you for joining us this evening. There's some things I want to talk about, but the whole purpose is also to give you an opportunity to ask a question of your governor. Ask a question that might be on your mind. I did recognize some legislators in the audience tonight, and I wanted them to, we got a number, in fact, we got enough of them that I think we could take some votes a little bit later if we needed to. But we'll decide later after the town hall meeting whether we should take any votes or not. But I am very honored that they're here. And let me tell you, I talk about some things that we've been able to do, and it's only a gleam in my eye as governor until the legislature supports it, until they get in there and work with me and refine it, and I'm very grateful to them for their leadership. And so could our legislators, I saw Senator Rapert, would you just stand up and introduce yourself and go around the room? And he's from away, by the way. And good. Well, that's an incredible representation here, both in this area, and Senator Rapert, you're sort of the host here, and Representative Meeks, Representative Beck, thank you. And of course, we got Dan Sullivan coming from a distance that I very much appreciate his participation tonight as well. And I wanted to, we got a number of other officials here. We've got some of my cabinet here that will probably introduce themselves as we go on tonight and have some questions. I'll interrupt and ask them to answer something and participate and introduce themselves at that time. I also want to recognize Tom Courtway, president of, where are you president? UCA. Great to see you, Tom. You've always been so supportive of us. I wanted to first, before I get into my presentation, just stop for a second and acknowledge the incredible incident, the terrorist incident that we observed in Belgium. In Brussels, what an extraordinary city, what a devastating attack, and our prayers and thoughts go with our Belgium friends during this time and as they respond to this real crisis in their community. I've spent time in their city. It is wonderful. Brussels is the only city in the world that has 3 U.S. embassies. So we have a strong presence there, NATO, Belgium, as well as the EU. So amazing city. It was targeted clearly, and our prayers are with the citizens as they respond to that. In this town hall meeting tonight, generally you come, and I want to talk about my $100 million tax cut that we've enacted with the legislature, the largest income tax cut in Arkansas history and a rate reduction. We've emphasized job skill emphasis here in Arkansas. We've put new teams in place. We're doing work in the job skill arena. Our computer coding that Terry mentioned is a national highlight. I'm proud of that work as well. But I wanted to focus now on the future. I want to talk about some upcoming legislative sessions. And as you know, I won't put it down then. We have 3 sessions of the legislature that will be coming up. April 6th, we're going to have a Medicaid reform session, followed by our regular budget session, and then followed by, hopefully, a highway session and other items after the regular budget session. So April is going to be a busy time for our legislators. It's going to be a busy time for me. And the first session is what I want to talk about, which is where we are in terms of our Medicaid program in Arkansas, what changes need to be taking place there. And then I also, before I get into my presentation on Arkansas Works, I wanted to mention something else, because Arkansas Work is a new emphasis. It is a significant change toward work requirements and work opportunities. But it's not just an emphasis in terms of this social program. It should be an emphasis in all of our social programs. Our social programs should be a safety net to help the vulnerable. It should be a hand up as people are going through tough times to get them back on their feet. But ultimately, if you're able-bodied and you're able to work, you ought to be working. And if you're not working, you ought to be in job training. And if you're unemployed, you ought to be helping somewhere. That's just a basic premise, and that, our social program should be an incentive for people to go to work, an encouragement for people to work. And so part of that is we looked at the SNAP program, which is the old food stamp program, and the SNAP program. It's a federal program, but your states were granted a waiver so that you didn't have to have a work requirement there. Well, I looked at that and I said, we got a 4.2% unemployment rate in Arkansas. We've got some counties that are still struggling. But at the same time, if you are able-bodied, you have no children at home, then you ought to have a requirement to work. And so we have instituted that. I did away with the waiver. We instituted a work requirement. And the work requirement says you have to either be working or you have to be in training, job skill training, or you can be volunteering for a charitable organization, a community organization for 20 hours a week. And that way, if you can't get a job or you're unemployable or you don't have the job skill training, there's not one in your community, you can always volunteer for the local food shelter. And so we put that requirement in place. At the end of this month, 6,000 people will lose their SNAP benefits. Now, that's not a punitive action, but it is a recognition that they need to be doing one of those 3 criteria. And so I hope you see from that we're serious about work opportunities, creating work opportunities for people in our society. And that leads me, though, to the new initiative on Arkansas Works. And let me give you a background, and I've got this up here right now. I'm going to take down for just a second so we can see you over there, Sam. But give you a little bit of history, and history is important, and some of you have heard this history. but it's important to understand where we are right now in the state of Arkansas. And so we had the Affordable Care Act, also known as Obamacare. I call it the Affordable Care Act. It was enacted, in 2010 after enormous debate. I campaigned against it. I lost. It was enacted, and it went into effect. It was challenged through the courts and eventually up to the United States Supreme Court. I asked Arkansas, I urged, and I supported the challenge in the court and believed it should be ruled unconstitutional. We lost. John Roberts didn't vote with us. And there were 4 parts to the Affordable Care Act. And this is important to remember. 4 key parts to the Affordable Care Act. There was the individual mandate that made everybody buy insurance. There was the employer mandate that if you had over 50 employees, you had to provide insurance that met their definition. And then you had the exchange that you could go on if you're middle income and get a subsidy for your insurance. And then you had the Medicaid expansion part of it for those who are under 138% of the poverty level, that you would be provided health insurance in that expanded population. You'd be provided Medicaid. So it goes to the Supreme Court, and what do? They throw us a curve. They affirmed 3 parts of it and said the last part of it, the Medicaid expansion part of it, is up to the states as to what they do. And so it came to Arkansas, and Arkansas enacted a unique response to that, which was the private option, which says we'll take those Medicaid dollars that are federal Medicaid dollars, and we'll allow the individual that qualifies to buy insurance in the private market and all of the criteria there. And so that was done. It was unique. It passed the legislature. It was funded. Well, the debate continued to rage on, and that is whether Medicaid expansion is a good idea. People continue to fight against it, saying that if enough states fight against it, it's going to collapse and the Affordable Care Act will collapse. Well, as time goes on and the Supreme Court affirmed it and it gets more ingrained into what we do, then all of a sudden you see 31 states that are now participating in the Medicaid expansion. And so that brings me to the current place we are in life. And when I got elected governor, I inherited all of this. I inherited the controversy. I inherited the Arkansas solution called the private option. I inherited the ongoing debate, the ongoing national debate, and that's what I inherited. Last year, I made a presentation at UAMS and said, as a state, we need to end the private option December 31, 2016, and then set up the task force to determine where we ought to go in the future. The legislature backed that up, and that gives us the deadline at the end of this year that the private option by law is gone. And so the question is, what do we do then? I recommended to the task force, which they have supported in terms of going to the legislature, and that is my reform called Arkansas Works. And it takes the current Medicaid expansion population that we have 250,000 plus on the Medicaid expansion population and say we want to take that value of work and make it a more important part of the program. That we want to take personal incentives to incentivize people for more personal responsibility, so they have to have a premium share. We want to encourage employer-based insurance versus simply government insurance. And we want to have additional program integrity, and that's the reform, and because it centers on work, I called it Arkansas Works. And so that is what I have presented to the legislature. I want to elaborate on that a little bit. But I also said we needed to create some savings, and that brings me to this chart that I also used at UAMS. And this is the entire Medicaid, not the entire Medicaid budget, but it is what is required from state revenues to support the Medicaid program. And what's in blue is all of the Medicaid program that is supported, the traditional Medicaid program, and what is in red here is the general revenues that eventually will support the private option. Of course, right now there are $0 other than administrative costs that support the private option, But over time, in 2021, there will be up to the 10% match that will be required to fund the private option. That's the state revenue share. And so, I'm afraid I'll tip that over. I was going to turn it so y'all can see it. And so, I think you get the idea of the pie chart, though, that if we're going to talk about reforming Medicaid, what part should we talk about? What is the most important part of talking about Medicaid reform in terms of state revenue budget? It's the blue part. The blue part is the biggest part of the pie. And so that is the point I made at UAMS years ago. And all of the debate centers around the red portion of the pie, but we've got to elaborate the debate on the big portion, the blue portion of the pie. And so that's why I told the task force that we needed to create savings. And I probably did not get my message just right. It's not a matter of creating savings so that we can fund ultimately the 10%, although that's part of it, but we want to create savings because it's the right way to manage a program that is so expensive to the state of Arkansas. And we have a responsibility to manage that program. And so that should be a serious part of the debate. And so I said that if we're going to continue with the federal Medicaid expansion dollars, then we need to reform the entire pie so that we create savings that can be sustainable over time. And as the task force then got the John Stephen Group as a consultant to look at those savings and said we can save money. In fact, they said we could save about $1.4 billion over 5 years. A significant amount of savings. They made some recommendations, many of which have been incorporated into the Arkansas Works program. And so I've added a part of it that we have another great need. And that is that we have a waiting list of, 3,000 people who are suffering from a disability, developmental disability, that is in need of care, and that we don't have the resources to provide the home care that is needed for them. 3,000 people on the disability waiver list. And I said, I would like to be able to take some of the savings from the entire Medicaid program and to apply it to reducing that waiver list. And so that's part of the Arkansas Works program. Now let me come back, if I might, and say, I want to elaborate a little bit on the 4 key reforms part of Arkansas Works. First is the work, and we have gone as far as we can with this administration with work, which is mandating a worker training referral to everybody who is able-bodied that is seeking expanded Medicaid coverage. And so if they're on the Arkansas Works program and they have 0 income, which means they're not working, then they will be referred toward for Department of Workforce Services, Director Bassett's agency over here, for worker training. And we want to enhance that as time goes on, but that's an important part of it, that worker mandatory referral for training. I did ask this administration for heavier mandates, but that's not consistent with their philosophy. Perhaps in a new administration, we can have more stringent requirements in regards to work. The second part of the initiative is personal responsibility. And that is, if you're making 100% of the federal poverty level, if you're making 100% of the federal poverty level, then you're moving up the economic ladder, and just like someone who's in the workplace or goes on the exchange to buy their insurance, you can be charged up to 2% of your income for a premium cost. That you would have a share and responsibility in your own health insurance. And so we would require, part of Arkansas Works, that personal responsibility that if you're making 100% of the federal poverty level, you would pay up to 2% of your premium cost as part of your responsibility. We would also mandate the acceptance of employer-sponsored insurance when it's available. This is important, and so I'm going to spend a little bit of time on this. Right now, if you are making, say, 130% of the federal poverty level. That means you're working for a company, and that company might provide health insurance. And so Company A provides health insurance to all of the workers, but employee B is making 138% of the federal poverty level, and he says, why do I want to take my boss's insurance? Because then I have to pay the monthly premium for that. And I have to pay a copay when I go into the doctor's office. And so I'll just opt out of taking the employer coverage, and I'll just stay on the Medicaid expansion population. That is happening time and time again in Arkansas because, and what it does, it's sort of a snowball effect because employers say, I can shed, some people off. It reduce some of my costs perhaps. Others look at it differently and say we actually need those people in our pool, but it distorts employer-based insurance because people are opting out of it for their own pocketbook and going on the private option. And so we want to change that dynamic and say that if the employer is willing, it's not going to be a mandate on the employer. The employer would need to sign up and say, I want to have my employees covered on my insurance, but if they qualify for the Medicaid expansion, we're going to enlist with you so that you can cover the wraparound costs for them. And then the employee is mandated to go on the employer policy, and their premium costs would be paid just like they were on the Medicaid expansion. So it equalizes it, but enhances and incentivizes and encourages employer-based insurance. And that is important because I would like to see a system in this country that is not all one payer. It's not always government. That we don't want to have our employer-based insurance die. We want it to thrive. We want to be able to encourage it. As part of it, that the Department of Human Services will be authorized to take some of the savings that we realize and share that with the employer to further incentivize them and reward them for continuing with the employer-based coverage. Now that saves us money because the more that we move from the Medicaid expansion onto the employer-based coverage, that saves us premium costs. And so that's a part of it. The fourth part is incentivizing work. And, excuse me, I covered that. It is the program integrity part of it. And it's very simple, that right now, that if you sign up for the private option, then your coverage is backdated 90 days. And so any health care costs that you had 90 days previously is covered even though you just signed up for it. And then the premium cost goes back also, so we're having to pick up 90 days of premium costs that you would not if you just went into effect on the day that you signed up for it. Now, if you're signing up for any other insurance policy, when does it begin? On the day of application. And so we want a waiver to allow us to put in the Arkansas Works policy at the moment of application. Now, I know there's some providers in here that say, well, how about us? Is that going to have a gap that we're not going to have coverage on someone that comes in? Usually, the coverage is triggered when they go in for a health incident. They have an accident or they have something that causes them to go to the hospital. The first thing that's done is, where's your insurance? Oh, you don't have insurance. You qualify for Arkansas Works. Let's get you signed up. And it goes into effect that day that would be covered. So there's got to be a smoothing aspect of it, but there's no sense us paying 90 days of premium cost going back. So logical, common sense approaches, significant changes in work, significant changes in terms of employer-based insurance, and this is why we call it Arkansas Works. This is a new program after the private option expires. Now, I've talked a long time. I've got more points to make, but I figure I can make those during the question time. So I'm going to stop there, and I want to turn it open for questions that you might have. And if there's a lull, I'll keep talking, and that's probably an incentive for you all to ask questions. But thank you for allowing me to go over that. Obviously, whenever we present our bills in the legislature, it's going to be an Arkansas Works bill. There'll be a savings part of that covers all of the Medicaid budget. And I could talk more about the savings side of it, but that'll be a part of the equation. And then we're also going to have probably a couple other different items to be released in the next few days. So with that, are there any questions?
We'll just take questions, raise your hand and we'll come to you.
And yes. Judge?
Governor, has the waiver that you're seeking, has it been given before to other states? Elaborate on that a little.
Great question. First of all, the waivers that are needed to implement Arkansas Works can only be granted after we pass the legislation that approves it, and then they'll look at the waivers. But I have had meetings with Secretary Burwell, and the waivers that I'm requested, I believe we can obtain. Secondly, to your point, many of them have been adopted in various forms in other states. For example, the work referral requirement was proposed by Utah. Didn't get through the legislature, but they were able to get that waiver. So the only one that is really new that my knowledge has not been tried is the employer-based insurance requirement mandate, which is novel for Arkansas, but we like novel approaches. I think it's very important. I think it could be a national leader in terms of setting that standard and setting that example of emphasis on employer-based insurance. But the others have been covered in different states. There are precedents for those, and I believe we can obtain the waivers that are needed. Great question. Yes.
Welcome to Conway again, Governor.
Thank you.
Kind of two questions, opposite ends. What happens if we say we just don't want to participate anymore? And on the other end, I've heard some people say, well, Arkansas Works is just too expensive, we can't afford to participate. Can you kind of talk about those aspects?
Absolutely. So the question, I think, is what happens if we just say we don't want it, we walk away from it? All right. Well, the answer is that, first of all, everything's in turmoil. And that's an important issue. When you're talking about our hospitals, when you're talking about our healthcare providers, you know, they have to project expenses in the next year. They have to project revenue and what's the future. And they make buildings and they spend money or they save money based upon the stability of the healthcare marketplace. And so if we ended it, it creates turmoil in the Arkansas healthcare marketplace. Secondly, it would be a huge budget gap presently and would create turmoil within the Arkansas budget. Why is that the case? Very simply, that whenever we took the federal Medicaid expansion program, they began paying 100% of those Medicaid costs. And we shifted a lot of our, where we were paying 1/3 of the cost, we shifted it over to where it was 100% covered by the federal government. We paid zero, and that saved us a lot of money. And so if we ended the program, many of those Medicaid patients would have to be transferred back to the traditional Medicaid. Not all of them, but some of them would be, where we have to pick up 1/3 of the cost. So there's additional Medicaid costs. It would hurt our Medicaid budget. Secondly, from the Department of Corrections, we had a huge medical budget for the Department of Corrections. Now that's being covered, some of their medical costs, because of the private option, the Medicaid expansion dollars. So we have to invest more at UAMS. We cut their budget because they had availability of insurance for some of the people that were covered, and then we would have to make up those dollars in some fashion back to UAMS. So it would be a huge budget gap in our state budget immediately. There was another part to the question.
The other part is, some people say that your Arkansas Works idea may be too expensive. Is that, in other words, can we afford it as a state? What's the additional cost that comes to the state?
And the answer is, that is a perfect question. It is the question I've asked from day one. And the reality is that at this very moment in time, and next year, according to the John Stephen Consultant Report for the next 2 or 3 years, it is a net plus for our state budget, and it helps us. Now, down the road, if you look at 2021, there's a cost involved. That's when we pick up the 10%. Now, that's why we create the savings in the overall Medicaid budget to make sure we're not going to be hurting our general revenue budget down the road. Now, what's the future going to hold? I would like to see and we might disagree in this room. Some of you want to see a Democrat president next year, and some of you want to see a Republican president next year. That's why we have elections. And so let's just game it out for a second. If a Democrat president gets elected, will the Affordable Care Act continue? If the Affordable Care Act continues, will the 31 states that are currently on the Medicaid expansion grow or decrease? It's going to expand. More and more states are going to sign up for it. And so if there's a Democrat president next year, and if we ended the private option right now and just gutted it and said we want to be done with it, we elect a Democrat president next year, then all of a sudden we're going to say, man, now there's 40 states signed up for the Medicaid expansion. Maybe we ought to re-up for that because that's the future and it's locked in. Well, that would really create a great deal of turmoil. You create turmoil now, disruption now, you're going to create more disruption next year. Now let's imagine it the other way if there's a Republican president. Now, if there's a Republican president, Senator Raper, what do we hope happens? Do away with it. All right, so if there's a Republican president, they might repeal and replace the Affordable Care Act. And so if they replace the Affordable Care Act, speaking as a governor, you know what I want? I want to see a block grant of all Medicaid dollars that comes to Arkansas so that I, as governor, can manage the program and not have to say, may I, for everything from the federal government. And that would include more stringent work requirements. That would include more flexibility in managing this program. And that would allow us to create all of the savings and continue to serve the people of Arkansas. And that's what I want to do with that big pie. I want to combine it and have a block grant. And so now let me ask you this question. If we have a Republican president that gives us a block grant next year and gives me what I want, then they're going to give us a block grant based upon the Medicaid dollars that we're receiving as a state. Now, if we diminish those federal Medicaid dollars right now dramatically because we do away with the Medicaid expansion population, you're going to shrink what we might get next year in cutting the deal with the federal government. And so we'd be in a better position to wait till next year to see whether we have a Republican president, a Democrat president, and make the best judgment for our state then. And that is the pitch I make is let's make the best judgment for Arkansas now, which is Arkansas works, continuing our path, and then next year, let's see where we are, and we'll make the best judgment for Arkansas next year as well. You know, I used to be able to answer questions without preaching, but something about being here. All right, great question.
Hello, Governor. Can we go back to premium sharing? I wasn't clear about that.
Yes.
I'm sorry about the wrong address.
No, you're
I
not
was
under
working at no pay in the yard when my wife said, let's go see the governor. So. But the premium sharing, and am I clear that you said an employee, if he's making 138% of?
If they make 100% of the federal poverty level or above, they would pay up to 2% of their income for premium sharing.
And what would that dollar figure be? What is that? Are you talking about a worker, family of four?
Well, if you're a worker and somebody might have to help me out here a little bit. Don Steele is our director of Medicaid.
Hi. It would be up to $19 per month based on the person's income.
Okay, $19 a month. If that is, they're making, if it's a single person, about $19,000. Now, if you have 3 dependents, you could be making up to $32,000 at the federal poverty level, so it could be adjusted, but it's up to 2%. So what you're thinking? Help me out here.
I didn't know the numbers.
Yeah.
I didn't understand. So the family of four making $32,000. Their premium share would be what? How much?
Well, if it's a family of, you just got to compute it. If they're making $32,000 is 2%, what's that? I'm sorry, what? $53 a month. Now I thought you were going to, I'll go ahead and answer this even if you didn't answer it. What are the consequences if they don't pay it?
Exactly.
Yeah, what are the consequences if they don't pay it? And the answer is that we actually want to have the discretion in the legislation that we can even waive that if they do certain wellness programs. In other words, we might waive that premium sharing because it gives us some leverage there because we have a premium cost in. Say, if you'll go in and do a wellness check every year, if you'll make sure you follow the doctor's guidance, then your premium costs will be waived. So there's some opportunities to incentivize healthy, active Arkansas lifestyles through that premium sharing cost requirement. Secondly, if they just don't do anything and you incur that premium, it becomes a debt to the state. And so theoretically, if they had an income tax refund at some point, you'd be able to collect it. But at least it's a requirement, and that's some of the consequences there.
Go, we have a question right here.
Governor, my son is number 387 on the waiver wait list. We have been on the waiver wait list since 2008. I am $40,000 in debt because Arkansas will not provide community support to my son who has autism. He doesn't suffer from it, he has it. The insurance industry fought hard to prevent the autism insurance mandate that was finally passed in the state to bring life-changing therapies to my child and to other children in this state. Now, my concern is no one in this room has mentioned the people that are making minimum wage, that are desperately trying to make a change in their lives. We're putting up all kinds of roadblocks for them to continue to get health care because we think they're lazy. They're not. I've signed up many kids for private option just because they come ask me because I teach about it in class. And you know what it is? I mean, the website's not easy. They need help doing it. But these are kids working 2 or 3 jobs because the state of Arkansas doesn't provide financial aid to help pay for their higher education. So they're not lazy, they're working hard, but they don't have any other way to get coverage. Now we're going to give them another roadblock, another means test, that they're not doing enough. There's also single mothers. So I'm concerned with the means test we're putting in place for the most vulnerable people in this state. The 3 carve-outs you've provided for nursing homes, the human development centers, and the behavioral health lobby all support institutionalization at the cost of living, at the expense of individuals living in the community. All 3 would indicate a move toward an Olmstead violation at the federal level.
Okay. Listen, I appreciate your comments so much from a number of different levels. One, thank you for sharing the heart about individuals who are trying to get things together in life and to work, and they come to you and they ask to be on the private option. You help them, but they're working, trying to do better. That's such an important point. Your point about the waiver list, number 200 and something on the waiver list, for how many years?
2008, we got on it, we were 892.
Okay.
Now we're 387.
Right. So it's 2008, that's well over seven years ago. And so the point is, nothing's been done for 7 years to address that waiting list. Well, I'm the state these days. And so, to my knowledge, I'm the only one that has a plan to reduce that waiting list. And the plan that I have presented to reduce that waiting list is not a cure-all. It's not going to go away overnight. These are huge financial lifts, but we need to get started on that waiting list. And if we can adopt Arkansas Works with the savings that I have articulated, then we can start addressing that. In fact, we have a trust fund that some of the savings would go in to start addressing that waiting list. So thank you for sharing that comment. Yes.
Thank you. My question is about individuals with mental illness and those with developmental disabilities and those with long-term care. I'd heard that you were talking about some that maybe managed care would come into this. Could you talk a little bit about fee-for-service and perhaps how managed care may play into that?
Great. See, that way I didn't have to give my long lecture on it. I could get a question, so thank you. And so the question is about this, the spending side. And we're going to have a piece of legislation that is going to set limits on managed care, that's going to have a Bill of Rights in there that outlines what rights should be protected for recipients, for providers, for the state. And in terms of the managed care, first of all, I was in Congress in the 90s, and managed care had such a bad reputation. And we had town hall meetings that were on managed care, and people, but it's been changed. And so they've learned a lot of lessons from that. The majority of states have some form of managed care. And so Arkansas is one of the exceptions that hasn't had it. And managed care, it's important to recognize, they do create savings. Now, how do they create those savings? Well, one of the ways that they create savings, which is a good way, is that they encourage people to manage their health better. They will have people that follow up. Does a patient are they taking their diabetes medication? Are they following the instructions from the doctor? Are they going for their wellness check? And that type of healthy lifestyle saves money. Now, what we did, because we needed to create savings, I asked different groups to come in and present savings plans. Some did. So we've got, like the nursing home industry is $250 million over 5 years that they put on the table that we verified independently can be saved. The only area that we're looking at managed care coverage would be for the developmentally disabled, excluding the human development centers and the behavioral health populations. Now, so it's limited in those areas, and then I want you all to pay close attention to the Bill of Rights that are in there. This is what North Carolina did before they passed any form of managed care. They passed a Bill of Rights. And we're going to do the same thing to make sure that there's a advisory group that's set up of beneficiaries and providers that can participate in the discussions, that provider reimbursement cannot be reduced beyond the Medicaid schedule without mutual agreement between the provider and the managed care organization. Those type of protections in place. And so, anyway, did I answer a little bit of your question?
No, sir.
Oh, all right, ask me again then.
I'm wondering how many on the Bill of Rights will include individuals with mental illness? How many individuals with mental illness will be included in the participation of the writing of that Bill of Rights?
Oh, participating in the writing of it? Well, I mean, as we go through the legislative process, I hope that everybody has a look at it, and that people can participate and they can speak their mind, and they can speak to their legislatures, they can speak to the governor and say, this does not protect those with mental illness. We need to have something there that is for us. And that can be debated in the marketplace of ideas. So that voice needs to be heard. All right.
Thank you, Governor. I'm wondering, especially in terms of long-term savings, what powers the state will have to focus on negotiating costs at the provider and insurance level, rather than simply focusing on number of people that are being aided by the program.
So, and you might have to ask me twice to make sure I get it right, but how much is going to be focusing on managing the cost side and negotiating the cost side versus just how many people are being served? And that's a good question, because that really is the kind of thing that will need to be articulated very carefully in the RFP, which is the contract bid for any managed care company, that we want to make sure that we manage the population, but also that they fairly negotiate prices, and that provider is not unwittingly reduced beyond what they should. So that is the contract negotiation is part of a managed care organization, their responsibility. Beyond that, which is on the limited populations, we've really done that with the long-term care. We've said that you need to put savings on the table. They've done that, so we've sort of renegotiated some of the relationships there, where there's, for example, independent assessments to determine the level of need for that long-term care, whether home care is better, whether partial care is needed, or a skilled nursing home. So that independent assessment is a very important part of the equation in determining what the cost should be. So that's part of what we're doing within DHS. You want to answer that any better, or Craig?
Obviously, I'm Craig Cloud, Director of the Division of Aging and Adult Services, Department of Human Services. To follow up with the Governor, obviously, as he's mentioned, the three components: behavioral health, developmental disabilities, long-term care, LTSS. Each area and component, the foundation is actually requiring an independent assessment to ensure that resources and services are allocated based on an assessed need. Within our long-term care specifically, our home and community-based sector, as well as our long-term services and supports that's provided in our skilled nursing facilities and nursing homes, is assuring that those residents across our state receive an appropriate, qualified, independent assessment that allows us to appropriately screen those populations, provide choice to them based on their needs, whether it be in a skilled environment or a home and community-based environment, and then as they are referred and offered choice to the most appropriate setting that meets their health and safety needs, we want to assure that both on the skilled side and the HCBS side, that we're creating the proper efficiencies in those programs to control cost, manage utilization, and ultimately bring overall efficiencies to the program and meet those savings objectives for that program.
Thank you. Yes.
How is Arkansas Works, how are you all, how are they going to monitor the work referrals? How people, because you're saying that people are going to volunteer for charitable, how are you going to follow up on that? Because I think, haven't we had some issues in past people not doing what they said they were doing or not being the person they said they were?
Well, great question. And first of all, the people of Arkansas want to work. There's a great work ethic in this state. People want to work. People want to have opportunities. You know, sometimes they need better job training. We need to get them that job training or make that available to them. Sometimes there's such a low level of skill, they have few job opportunities. And that's a real challenge in some areas. And that's where we always need to remind ourselves there need to be that opportunity for support for voluntary organizations, just so there's work and the dignity of work, even for somebody of low skill. We also need to bring those jobs in. So, one, it's a mandatory referral. So DHS, as part of their policies, have to do the referral. And then it will go over to Director Bassett at Department of Workforce Services. And Director, you want to address any of that? How are you going to handle it when you get those referrals?
First of all, it's processing. Our experience is that these individuals want to work. And quite often, it's a situation of where they are not aware of what's available for them as far as training. What we're doing is investing initially in assessment tools so that we can determine the level of preparedness of these individuals. Then they will be referred to either our adult education centers, our 2-year colleges, or our 4-year colleges. And so that's how we're attacking the initial wave. With regard to able-bodied, we know that we've got a population out there of around 50,000 right now, split evenly among those with children and those without. We're going to address both groups through our assessment tools.
Thank you. Well, all right, do you want to add to the question is, what are you going to do when somebody doesn't do what they're supposed to do? That's a fair question. You answer it quickly.
Very fair question. When they come into our system, they are assigned a case manager. A case manager follows them through the system, through the referral system. They'll be tracked through our AJL, our Arkansas Job Link system. So we'll be able to track these individuals and find out where they're going and look at their success rate. If some of them are falling down, then our case managers will have the responsibility to readdress that case, bring them back in, and find out what services are needed.
And I'll be real straightforward that I would like to have more stringent work requirements. I cannot get those from this administration. That is something that I have to work on in a new administration or with the block grant proposals in the future. And so we have pushed the work side of this as far as we can, which is the mandatory work referral, mandatory worker training referral. And like we've said, I believe the vast majority of Arkansans want to. I think this lady described them very much, that they want to work, they're coming to you. Some of them are young, some of them are older. And so it's really the exception to the rule that somebody doesn't want to engage in that. Well, we've got, obviously, some people want more stringent requirements in there. Some people are concerned with fewer, and obviously you got to be practical in it. And we've actually I've personally talked to the Secretary of Labor about additional support for things like transportation, and there are some funds for helping on transportation costs when they need assistance in training. We'll continue to look at that. But those need to be factored in as we develop the rules to encourage that work.
Matt Troop with Conway Regional Health System. First and foremost, thank you for having this venue for us, and I can appreciate the difficulty and the complexity of the topic that we're discussing in your creative venue, and us having an opportunity to give you feedback. I guess if we can, I'd like to go back to managed care, which is a topic near and dear to my heart, being in healthcare, and really two questions. One is the issue of medical issues in managed care, in the categories that you mentioned before, when those individuals have to access acute care or providers outside of behavioral health and nursing home care. Very often, behavioral health patients end up in our hospital, even though we are not a behavioral health entity, and the complexity of how you manage those medically complex patients with behavioral issues. And I just am curious to know what your thoughts are there. The second question really relates to the Accountable Care Act. And there's a great deal of innovation going on within the payment arena with shared savings programs, accountable care, patient-centered medical homes, a lot that as an industry we're very knowledgeable of, but the general public is not. Is the state considering any shared savings type models that you might see at the federal level that really allows us to work more directly with the in-source payer? Managed care historically, it's just a well-known fact, has about a 15% cost structure that they carry with them. Whereas in a lot of these other models, we can do that a lot more efficiently as providers. So I'd just be interested in those 2 points.
Well, your hospital.
Yes.
Matt, you know my talking points here that, there's, you have to support Arkansas Works, which you like, is that right? The Medicaid expansion, because it helps the hospitals, it helps the coverage there, it helps the person that's coming in that has some coverage. It helps patients. All right. But on the other side of the coin, in order for this to be affordable in the long term, we have to create savings. The managed care is one small part of it in limited populations, and that does impact you. Because if you have a behavioral health, if you have somebody with a developmental disabled, they're in a managed care, and they have a physical injury and they come in the emergency room, it does impact you. But that's where you've got to look at the Provider Bill of Rights. And I'm going to ask the Surgeon General here just a comment here in just a second on this. But I'm not saying there's not going to be some cost consequence by the managed care, but it is necessary and a good balance. And that's a key part of it. Secondly, you mentioned like the Payment Improvement Initiative, the patient-centered home. These are still part of the mix of what we have in terms of case management at DHS. But we also have, for us to really manage huge contracts and to oversee the system, we need the private sector's help, and that's where a managed care organization comes in with some expertise. And so I hear what you're saying. we did not go full-blown managed care, and if you see this legislation, it says limiting managed care to these particular populations. And so it's really legislative protection for a more expansive managed care program.
Well, hey, I'm Greg Bledsoe. I'm the Surgeon General, and I think it's an excellent question. I've done clinical emergency medicine for probably 15 years all over the country, and you're absolutely right. I mean, one of the things that happens is the frequent flyers, if you want to call them that, or the super utilizers are often people that have significant problems, including behavioral health. One of the interesting things, though, is that when you look at why they're bouncing back to the emergency department, a lot of times it's things that are social issues. And there's been a lot of research and a lot of discussion on something that's called the medicalization of social need in America. So one of the reasons why people aren't taking their medicines is because they don't have electricity at their house and their medicines don't keep, or they don't have someone to drive them and give them transportation to the various places where they need to go. So in theory, at least, someone who's managing their case more effectively would be able to get them and plug them into all these different things so that they're not falling in these gaps and ending back in the emergency department. The key, though, is to write the legislation and have safeguards so that services aren't being cut and the people are still getting served. And that's where the Patient's Bill of Rights and the Provider's Bill of Rights comes in. And that's why we feel like it's so important that we pass those first before we even have a discussion about managed care.
Thanks, Matt. Yes.
I'd also like to apologize for the attire, Governor. I am on spring break, and we had a lovely day in Conway today. So I'm going to be shaking a little bit.
You look great. Take your time.
I'd first like to mention that we've had a privatized system well before the Affordable Care Act. And so, just a quick conversation topic, would you think we'd even be having this conversation right now if it was never passed?
If the Affordable Care Act was never...
Yes, because the pressure that it's placed on the states, would we even be discussing health care and its reforms and trying to reach out to the citizens and cut down costs and everything if we didn't even have the pressure on Arkansas? And then secondly, to what extent are we currently, and then are we, through your plan, going to reduce the gap of people who are too poor to be under the or the gap of people who usually their income does not allow them to be covered by the program? Having been in the NHS in the UK, everyone there was covered, and so my family didn't have to worry about that. In Florida, they denied the Affordable Care Act expansion, and my family are caught between that gap. Obviously, they've had to make the ends meet as far as healthcare coverage. So here in Arkansas, what can we do, or what are we going to do to make sure we don't have people stuck in that gap?
Great question. The first one was about whether we would even be having this discussion today if we did not have the Affordable Care Act in place. And I really think, one, we don't know, because that's rewriting history. But I would like to think that health care and how we treat people and care for people and have coverage and meet health care needs is an ongoing discussion that we're going to have every year. And particularly, but the Affordable Care Act has prompted much more intense discussions, and that's where we are today. And then the second part of your question is about the gaps in coverage. And there's, and I'll let somebody correct me if I'm wrong, but we have everyone covered that are blind and disabled, the aged, in the traditional Medicaid. We have now the coverage for those making between 0 and 138% of poverty. And so there's your coverage. And then if you're making over 138% of the poverty level, what happens? What's that? You go on the exchange. You go on the exchange and you get subsidized based upon your income level. And so so there is coverage all along the way. Now, obviously there's gaps. If you get above, 400% of the poverty level, then there's no more subsidy for you. And that's the American system. Now, but I want to take advantage of your question, which is a very good question, and make this point that gets me in trouble sometimes, but I believe in it. And that is that because of the difficulty, the Affordable Care Act, because of the Supreme Court decision, the choices we have, if we did away with the Medicaid expansion, what do you got left? You've got that person, if you imagine in your mind, who is the waiter in the diner, the waitress in the diner that makes the federal poverty level and living on tips and got a couple kids at home, who for the first time has health insurance because of the private option and she's working. If we eliminate and cut it off and don't vote to do anything, she loses her coverage, right? But then that person who's making 200% of the federal poverty level, does he lose his coverage? No. He still gets to go to the exchange and get subsidy. Now, there is a little bit of a fairness concern for me, because I do not feel right as a governor to say we're going to be in a state that willingly cuts off those in the lower income, but we're going to continue to subsidize the higher income levels with taxpayers' money. And so for that reason, I think it needs to be continued in whole until we win a battle in Washington, or we have a new direction or different policy. Thank you for the question. Y'all have been a great audience. One, you're very kind. And you've listened to me a lot, and I'm very appreciative of it. We've gone beyond the time, and I don't want to cut anybody off from any question, but I also don't want to belabor the point. So are there any other questions? Yes, sir.
Thank you, Governor. I had two questions. First, will there be an increase in resources for workforce services under Arkansas Works?
Great question. Will there be an increase in resources for Arkansas Workforce Services? Because obviously there's more training requirements. There's more people that, because there is a work referral mandate, that they're going to have additional burdens placed on them. And so the answer is we're looking at that. We're trying to marshal our resources. I've worked closely with Director Bassett trying to address that challenge for you, and the legislature will have to look at that as well.
Thank you. And my second question, I was a little confused about the personal responsibility factor of Arkansas Works. I believe I heard you say that 100%, or for people that make 100% of the federal poverty guideline, there's a possibility that up to 2% of their income they'll have to pay as a shared responsibility component. For most people that are around 100% of the federal poverty guideline, I would think that most of their income consists of supplemental Social Security or Social Security disability. Would those persons who have either most of or majority of their income coming from Social Security benefits also have to pay that up to 2%?
Well, first of all, thank you for the question. And most of the people that would be qualifying for this expanded population, this is not traditional Medicaid, so most of those are working. The majority of those are working, have jobs, working, could be for minimum wage, but they're working. And so they wouldn't be dependent upon Social Security and those types of income. They have different types of coverage there. And so there is that disposable income. The reason it was, first of all, the first debate was whether everybody should participate. If you're making, 50% of the federal poverty level, should you, participate and pay a couple dollars as a co-premium cost just to give you some ownership of it. We were dissuaded that that's a bad idea because of the concern of their income level. But if you're making 100% of the federal poverty level, if you get to 138% and go on the exchange, you have to pay up to 2% there. And so that's the reason we picked up to 2%, is because, it's it gears you into moving up the economic ladder. Secondly, we want to provide those kind of incentives or encouragement that it can be waived if you do certain lifestyle behaviors that can save on healthcare costs. And so there'll be some potential in there to create some waivers for those that can earn it through their healthier lifestyles. And then finally, I think we find that people who contribute, whether it is through a voluntary organization, through a copay, they have pride in the fact that they are participating. And that pride and that ownership and that responsibility is part of it. And so we're not trying to create hardships, we're trying to move people up the economic ladder. We need to listen to people and make sure we refine these so that we can accomplish those goals. Thank you. With that, I think we've covered it, and y'all are great. Give yourself a round of applause, please. And I'm delighted with the legislators that are here. Was this good to hear? Good feedback, good helpful information, great questions, and shucks, who knows, you might encourage me to have another town hall meeting. But we'll see. Listen, thank you for giving me your time tonight. God bless you.